last class I was telling you about the coagulation system, isn't it? So you know what are the factors involved, what is the intrinsic pathway and what is the extrinsic pathway. So in day-to-day life inside the body, small wear and tear will be happening, where there will be internal bleeding and get clotted, and internal clotting that get again dissolved, the clot get dissolved. Okay, that is a normal process happening. So actually as per the syllabus what I have got, they give one drug called as epsilon amino caproic acid. That's all they give. That is coming under anti-fibrinolytic drug. But before we directly jump into that, I'll give some introduction of what is that. Now we told last class that we have intrinsic pathway, extrinsic pathway, and there is a common pathway, and finally fibrinogen gets converted to fibrin. So there is a formation of clot. For any factor, either if this gets activated or this gets activated, there is a clot inside the body, right? So this clot cannot be for a longer time. The clot has to dissolve. Once the repair process is completed, the clot has to get dissolved. So for that we have a system called as fibrinolytic system. They come and lyse the clot so that again the blood can start moving. Suppose if there is excessive bleeding, we have anti-fibrinolytic system that can come and stabilize the clot. If there is bleeding, the clot can be formed. If there is clot, it can again make it blood thin. Okay, so we have fibrinolytic system and anti-fibrinolytic system. So what the drug I got from your syllabus was anti-fibrinolytic system in this case. So what I will do is I will combine both the thing and give the difference so that you can understand easily. So the drug what I have been given is, one is epsilon amino caproic acid and the second one is tranexamic acid. Tranexamic acid. This comes under anti-fibrinolytic drug. See, tranexamic acid is an anti-fibrinolytic drug. This, they are coming in this section where they can stabilize the clot and prevent the bleeding, right? Now I'll show you a picture here. Now you can see in this case. Now I'll start with the intrinsic, what is happening inside the body. Now if there is a factor 12A or kallikrein or tissue plasminogen activator, if this gets released, plasminogen, which is inactive, converted to plasmin. The plasmin converts, you can see there, fibrin to fibrin fragments. So coagulation pathway there, you got fibrinogen, fibrin gets lysed. So that is involved in breaking down the clot. So that causes bleeding, isn't it? If there's any clot, we can use those drugs. The extrinsic, this is we are giving in terms of drugs. Streptokinase is a drug, urokinase is a drug, and recombinant plasminogen activator, RTPM is recombinant plasminogen activator. This we can give as a drug, but that is not given for me to deal for you. But these are the drugs that can be used if there is any internal clot. But what I have been given here for you is epsilon amino caproic acid, tranexamic acid. This is also called EACA, this is short form. Tranexamic acid, aprotinin. So this is we are giving as drug. Whereas internally we have these two that can be produced physiological. Alpha to antiplasmin or alpha to macroglobin. If this activates, this inhibits. See, plus means activate, this is inhibit. What happens? This is not converted to that. Plasminogen will remain. If plasminogen will not come to plasmin, the fibrin also will not get to degrade forward. So that clots remain. So prevents the bleeding. Got the idea now? So I have been given for you to deal with this group. Right. So that is why we call it as anti-fibrinolytic. For example, now directly we can get use of this. Suppose somebody has got clot inside the pulmonary vessels. You want to break the clot. Okay. Which one you are using? That or this. There is a clot already. You want to break the clot and make the blood to move. Whether it is fibrinolytic or anti-fibrinolytic. Fibrinolytic. Lysis means breakdown. Fibrin lysis. So you use fibrinolytic system that you are using, isn't it? Suppose already there is a bleeding, excess bleeding is there. You want to stop it and make a clot. What you will use? Antifibrinolytic you use. Isn't it? Now I think you got it. Now a simple rule I will tell you. Suppose for any case, unknowingly or miscalculation, you give an overdose. What is antidote? This. Suppose this you give overdose. Which is antidote? That's a pharmacology. Understood, no? So the first use of this, if they ask you also, you can tell in overdose of fibrinolytic, we can use this drug. Emergency use. Somebody came with a clot and you started using that. By miscalculation, you give overdose. Immediately, what you are doing? I'm the antifibrinolytic. Which is a drug? I have this in the market. Understood? So in case if you give this overdose, what you do? I can give that. That is not available in the market. Whenever any drug name ends with kinase, ACE, they are all obtained from microorganism and they are all nothing but enzymes. Okay? Now we are dealing with this. So because as I got the syllabus to deal only with this, I am only dealing with this. Understood? Let's see here. So I give the full form here. What is RTP? It is a, so we have a tranexamic acid. Tranexamic acid. So what they do? In the exam you are writing only this much. Write this, inhibit, prevent the conversion this to this. So that clots will get stabilized. There is no bleeding. Understood? So how you write in the examination? This tranexamic acid competitively inhibit activation of plasminogen to plasmin, correct? Prevents fibrin clot breakdown, stabilizes the blood clot and prevents bleeding. It stops the bleeding. Simple action. Either you can write in the flowchart or you can write in the sentence. That's all. Then you want to go to uses. Where you want to stop this bleeding? General uses. Menorrhagia, heavy menstrual bleeding. In the market you get the drug. When you are writing in the prescription, you are writing like this. You know what is RX? Number one, tablet. It's not available in the market as tranexamic acid. PAUSE. Pause. Or also have pause MF. Go and find out the ingredient in that drug. There is heavy menstrual bleeding. Then you can do this pause and pause MF. Find the ingredients, the company which prepared that, the cost of the tablet, everything you should find out. That is your duty, okay? Epistaxis, if there is nose bleeding for some reason, okay, you can use this tranexamic acid. Surgical uses during cardiac, orthopedic, dental, ENT surgeries to reduce the blood loss. Because you put the incision and somewhere the bleeding is not getting controlled, then you can use this drug. After putting incision, if the bleeding is not stopping, you can use this drug. Emergency use, your case, trauma-related hemorrhage, road traffic accident, he came and bleeding is not stopping, then you can use this. Postpartum hemorrhage, what is postpartum hemorrhage? Refers to excessive bleeding following the delivery of a baby. Sometimes, once the baby comes out, afterwards the placenta should come out. Sometimes all the lobes of the placenta will not come out. Some portion may remain inside, and that is the reason for excessive bleeding again and again. Then, along with using some drugs to contract the uterus to remove the remaining part of the placenta, you can control the bleeding by giving this tranexamic acid. Postpartum, after delivery, the bleeding is not stopped, she becomes very weak and anemic and she may die also because of the shock. So you can use this. These are the emergencies. These two you should write in your examination because these are emergency related. This surgical also you should write, and that is in your general you can write. So you get for 5 marks uses of tranexamic acid. This is what you should write. Right? Come to dose. That's what they will ask in the exam. Dose and route. Dose for menorrhagia 500 to 1000 mg 2 to 3 times per day. It's short acting. 6 hours once you give oral. Trauma and postpartum hemorrhage 1 gram intravenous for 10 minutes push. Okay? Repeat after 8 hours if needed. Intravenous. Surgical prophylaxis. Before you start doing any surgery, you can prophylactically give this drug and start the surgery to prevent excessive bleeding. 1 gram IV before incision. Repeat if needed. IV or oral can be given. Prophylaxis to prevent. Okay? Come to adverse effects. BATH, blurred vision or visual disturbance, allergic reactions, rash, urticaria, thrombosis because already it's forming a clot. The patient is susceptible for any blockade in the coronary artery or somewhere in the cerebral artery. No, it is. So you should always know the bleeding time, clotting time before you start this. Right? So rarely it may cause clot, thrombosis, and headache, dizziness, and GA, etc. Some of the other adverse effects of this tranexamic acid. Contraindication to whom you should not already it is causing some blurred vision. So if patient already has a color vision defects, you should be very careful in giving this drug. Active thromboembolic disease is already having a clotting disorders, and you are giving the drug to go and clot again. You are aggravating the condition. So in that case, you should not give this drug. And thrombogenic disorders, deep vein thrombosis, pulmonary embolism, this is also clotting disorder only. There is already susceptible for intravascular, like DAC last time I told, disseminated intravascular coagulopathy. Multiple clots is already getting formed, and if you use this drug, again clot will get aggravated and it will cause complication. These are the contraindications. What are the precautions? If patient has some renal impairment, dose adjustment should be accordingly required. History of thromboembolism, use with caution. That doesn't mean you don't use, but frequently check the patient blood parameters. Concurrent use with estrogen-based hormone therapy. Estrogen is known to cause already clot. If a patient is taking some oral contraceptive pill to prevent the pregnancy, she is always having a susceptibility to get intravascular clotting. In that case, if you give this drug, again it will aggravate the condition. So it may increase thrombotic risk and she may get heart attack or paralysis, stroke. Then ophthalmic symptoms. Regular eye exam recommended in long-term use. Suppose if you are using for long-term, 3 months, 6 months once, we tell the patient to go and check the retinal examination too, because blurred vision already we told in the adverse effects. So you should be very careful about that. Now come to the next one, fat soluble vitamin. That is also over. Tranexamic acid over. I am just dealing with all the drugs that is affecting the blood and blood component system. Okay. Fat soluble vitamin and coagulation. Any vitamin that is affecting the blood. What are the classification of vitamins? Biochemistry. Water soluble, fat soluble. What are the water soluble? Water soluble is B complex and vitamin C. B1, B2, B3, B7, B6 and all is there now. This is all what is including vitamin C. And fat soluble is A, D, E, K. Okay, in this bunch of vitamins, which is the vitamin that affects the blood? Last time I gave the hint of that. German spelling. Vitamin K. K for coagulation, it was German. But English C. So we are dealing with vitamin K. Vitamin K help for blood coagulation. So what are the 3 forms we have? Vitamin K1, phytomenadione. You are getting this from plant. Vitamin K2, menaquinone, produced by gut flora, normally inside your body. Even today it's producing. Understood? Then K3, menadione, synthetic origin, synthesized in the laboratory. Sometimes somebody has taken antibiotic there too, and they got bleeding. Why they got bleeding? Because the antibiotic killed the normal blood flora. The normal blood flora is inhibited. This is not produced in the body. This is not there, bleeding occurs because there is no coagulation system. Vitamin K is not there. No? So if they ask you why patient got bleeding because he has taken vitamin K, because not vitamin K, because he has taken antibiotic, this is the reason. If normal gut flora gets destroyed by your antibiotic, K is not there. Vitamin K producing flora also may die, gut flora, normal microbial. So because of that, patient may get bleeding after you start the antibiotic. K1, you get where and all you get K1. Spinach, broccoli, kale, vegetables, oils, etc. But K2, normally by the colon gut flora, and K3, water soluble, used in labs, rarely clinically. This is not used usually in the clinical practice, rarely used, but used for laboratory purpose or some other experimental purpose. Now what is going to do? Vitamin K acts as a cofactor for gamma glutamyl carboxyl enzyme, enables calcium binding. When the calcium binds to this factor, there is coagulation. These factors are not effective if there is no calcium. That's why you are adding, while collecting the blood in the tube, blood collection tube, you are adding EDTA. that chelates the calcium. EDTA binds to calcium. When the calcium is not available for the blood will remain in the liquid state. If you don't add EDTA, inside the tube the blood gets clotted because calcium binds factors and causes clotting. That's why whenever you get any injury, within few minutes it has to clot. Understood? The same thing. That's why they add EDTA. There is calcium chelating agent. They go and physically bind and prevents interaction with clotting factor or activation of clotting factors. And there is no calcium, it remains in the liquid state. In this case, what is happening inside the body? Vitamin K acts as a cofactor for this enzyme. An enzyme helping for this calcium bind to this factor, and because of this factor, there is coagulation. So vitamin K helps for coagulation. Now, last class I told you about the heparin, isn't it? And I told that there is one more drug which is given orally. What is the drug? Warfarin. It's obtained from what? Grass, I told. Alpha grass. Have you went and checked? Just write warfarin history, alpha grass. Type in Google and check the story. Whenever you learn something with the story, you will never forget. Now you can't forget McLean, the medical student, MBBS, how he found out the heparin. He was doing something research and he got something else, isn't it? In the same way, find out the. So we can see here. See, now vitamin K. Vitamin K, this is oxidase form. Vitamin K epoxide, oxidase form, and NADH. When this in presence of vitamin K reductase gets reduced, so NADH gets reduced to NAD, whereas oxidase form of the vitamin K becomes reduced form. Vitamin K hydroxyquinone, and that you can see there without carboxyl group gets carboxyl group, and that is when it is formed in the blood clot. I repeat again. We start from here. Vitamin K, oxidase form is coming here, right? With the NADH going from here. By the enzyme, vitamin K reductase gets reduced. This gets reduced to form NAD, and that will become reduced form of the vitamin K. And that is what it is doing this. The factors 2, 7, 9, 10, which is not having carboxyl group, gets carboxyl group. When this gets carboxyl group, clot forms. This is the action of vitamin K. Whereas you can see the warfarin will inhibit this vitamin K reductase. This is completely not there. So instead of blood clot, whatever in opposite there, bleeding. That's the action of warfarin. In the same pathway, we got both the action. Vitamin K also helping of clotting. Our warfarin, alpha grass we told. That is also we know how does this. So this is given orally. When the heparin was given parenterally, IV or subcutaneous, and heparin was acting by what? Antithrombin 3 we told. You studied that also. This is the vitamin K. I hope you can understand this, and you can write the same thing in the examination. Even when you write vitamin K, if you write this also, you will be very happy. They may not ask this, but if you write, you don't lose anything. Understood? Uses, general use. Vitamin K, only if there is a deficiency in some newborns, after you do analyze or assay, you can use newborn prophylaxis. Maybe baby is born and having some bleeding, and you saw the vitamin K assay, it is reduced. You can replace it. Warfarin overdose, can you use this? Warfarin was causing what? Warfarin was causing what? Bleeding. In overdose of warfarin, what is antidote? Vitamin K. We already use forming clot. See, so easy it is. See, I gave this, no? So there is a bleeding is there. So I gave a vitamin K. So what is happening? It is affecting this. Forms the clot. So vitamin K, first emergency use is overdose of warfarin. What is the emergency use of vitamin K? Is overdose of. That is the first use you write because you are in the emergency department, isn't it? Other thing you can write later. Okay. So first is overdose of. So what is the antidote for warfarin toxicity is vitamin K. Finish. And how does that? You know this pathway. Same thing you write in the examination. Antidote. Can you see that? Bleeding due to liver disease, emergency use, or malabsorption syndrome. Suppose the vitamin K, especially you give some drug. For example, the patient is having colon disease, celiac, Crohn's, or some disorder, even he has taken antibiotic. So I told the colon bacteria dies. Vitamin K is not produced in the body. The patient is having bleeding because of use of antibiotic, right? And vitamin K has saved it low. Replace with vitamin K. Sometimes we'll tell if patient already has some clotting disorder, we'll tell the patient to avoid those foodstuffs. I told them spinach and all those things. We tell them to avoid because it's causing enhancing the clot. If somebody patient is having bleeding, then we tell you have that foodstuff more because it will help you to reduce the drug and control the bleeding through this foodstuff only. Naturally, you are getting why to go for adverse effects of the drug. So that's how you can use these drugs. Warfarin overdose, you can use vitamin K dose and route 1 to 10 mg oral. That is, if there is no bleeding, but overdose is there, but bleeding is not there. For example, to know how much the warfarin has affected the body, we do one test called INR, International Normalized Ratio. That is there in my pharmacology. We can go and check on table I given. Warfarin dose and the concentration should be only this much in range level. If it exceeds that means warfarin overdose is there and bleeding immediately starts. So for routinely you check warfarin overdose is there, but patient still has not got bleeding. Then you can start prophylactically 1 to 10 mg oral. Or overdose is there, patient already got the bleeding. Then 5 to 10 mg plus fresh frozen plasma. FFP means fresh frozen plasma, or PCC. You find out what is PCC means. I'll tell you in the next class. Slow IV. Vitamin K deficiency is there already. Give 10 to 20 80 oral or IM. And newborn prophylaxis 0.5 to 1 mg within 6 hours of birth. You can give intramuscular. So it has all the three routes. Oral is IV is IM. Come to adverse effects. PA or PHAV, FAB. Pain at the injection site, especially when you apparently hypersensitivity reaction can occur. Altered liver enzymes rarely, and bleeding, ineffective liver failure. Actually, should cause what? Clotting. But the patient already got liver pathology. Then instead of clotting, it may cause bleeding because the drug is ineffective. You need a liver to help for clotting factors. Factor 2, 7, 9, 10 we told. Now liver is there. Now liver only is failure and there is no factor 2, 7, 9, 10. What this drug will do? It will go and inhibit all the pathway, but the factors only is not produced. It is wasted. So it causes bleeding. Okay. Contraindication. If patient already having history of hypersensitivity reaction, don't give vitamin K. Hemolytic disease, bleeding disorder. Okay, hemophilia A and B is there. Then avoid IV push. Use slow IV, not rapidly. It may cause sudden clot. And neonates avoid Menadione K3. K3 I told rarely used, I told, but don't, even if you are using, only use in adults, but not in the children. Precautions: IV administration must be slow to avoid anaphylactic reaction. Liver failure may be ineffective due to deficiency in the clotting factor, as I told you. And patient on anticoagulants, monitor INR, International Normalized Ratio. They will ask you for 5 marks, either pharmacology or in your MS. What is INR? They will ask you. International Normal Ratio. So you should write full form, principle of the test, and normal values. Remember what three things you should know: full form of INR, then what is the procedure, what the principle of the test, then normal values. This is a 5 marks question. So with that we finish vitamin K. So we'll end the class today and we'll continue tomorrow. Time's up.